It is Professor Dr. Tareq Shaarawy. He is also the international figure of glaucoma and a well-known worldwide pioneer in glaucoma, like Dr. Ahmed Mustafa. We hope that we get benefit from Dr. Tareq Shaarawy. And we say welcome. مرحبا دكتور طارق.
اهلا وسهلا. اهلا مرحبا بك. اهلا وسهلا.
انا طبعا احنا شرف لنا انك تكون معنا في الاجتماع اللقاء العلمي هذا، ونتمنى نستفيد كثير جدا جدا منك ان شاء الله.
الشرف لي وبالتوفيق دايما، وانا سعيد جدا للدعوه الكريمه، ويا رب دايما من احسن لاحسن.
شكرا. نبدا ان شاء الله القاعده العلميه.
تفضل.
So, glaucoma, the most important complication of glaucoma is hypotony. We see to many complications. So, الآن صار في اكتشافات جديدة أو محاولة إن إحنا كيف يعملوا minimally invasive procedure عشان to avoid this complication اللي هي بتاع gold standard tareq. So, دكتور طارق الآن يبدأ لنا هذه البروسيجر different new procedure innovation.
نيو علينا كلنا مايكرو invasive surgery، يعني جديدة علينا كلنا، يعني ما حد اشتغلها في اليمن وقليل جدا اللي بيشتغلوها في مصر. والدكتور طارق شعراوي غني عن التعريف. يعني الدكتور طارق، حضرتك تسمعني دكتور طارق؟
سامع حضرتك.
يعني حضرت مؤتمرات كثير في اوروبا، والاقي اسم الدكتور طارق شعراوي الاسم العربي الوحيد بين المحاضرين والمنظمين للمؤتمر، وكنا نفتخر. يعني we are so proud of you really. يعني
ربنا يخليك. لكن هو بالتاكيد مش الاسم العربي الوحيد، في نجوم كتيره قوي من كل الدول العربيه الحقيقه بيشاركوا في المحافل الدوليه بمنتهى القوه. فيعني انا واحد من مجموعه كبيره الحقيقه، وشاكر جدا كلماتك الطيبه.
اتفضل حضرتك، احنا جاهزين. اتفضل حضرتك ان شاء الله.
انا زي ما انت واخد بالك المحاضره بتاعتي مسجله، فحضرتك ممكن نذاعها وبعد كده انا جاهز للاسئله.
ذيع المحاضره وبعدين نبدا الاسئله ان شاء الله.
المحاضره جاهزه صوت وصوره.
Good morning, dear colleagues. What a pleasure it is to be speaking to you from Geneva, Switzerland, sharing in your manifestations for the Glaucoma Week. I have a lot of admiration for my colleagues from Yemen. I have excellent relationships with my colleagues there, and I have been watching with amazement and with a lot of pride all the social media events and the community events that you are doing in your beautiful country. وطبعا في ان ربنا اليمن دايما بالسلام والرخاء جزء كبير مهم لقلبنا. اتربينا ذكرياتنا مع اليمن ومع العلاقه الخاصه جدا ما بين مصر واليمن. When we look about glaucoma surgery, we have to identify that glaucoma surgery is not just a science, it's an art. Science deals with logic, with analysis, and with communication, and art has a lot to do with intuition, creativity, and emotions. And as glaucoma surgeons, we have to combine both science and art. I have been in this business for maybe 30 years now, started with trabeculectomies and deep sclerectomies, and with lots of years, lots of devices, lots of white hair, less hair, and all the way to MIGS and Zone and pressure flow. So let's discuss a bit about why is surgery important. We will discuss when, the advantages, the disadvantages, which procedures touch rapidly on complications and follow-up. First of all, when you try to choose an operation, it is extremely important to evaluate the conjunctiva. Don't be afraid to take your time to see if the conjunctiva is in good shape or not, because the success of your operation will rely very much on the quality of the conjunctiva. As you can see here, I'm even taking a cotton swab and moving the conjunctiva to be able to understand if this conjunctiva is healthy or not. And one other thing that I would like to share with you is that I use this speculum, and I use 8-O-Vicryl to be able to fix the eye. And here the eye is operating on eye drops of cocaine 5%, so nothing else, and we fix it with an 8-O-Vicryl with this speculum that I have crafted many years ago. I have no financial interest in that, and you can see it gives you a big area for you to operate. Now, there are lots of devices now, and you can see the devices in terms of size and in terms of shape compared to a coin. And if we look at what is available in the market, it's such a big scope of different procedures and different implants, and it looks like a fruit salad. It is very difficult to make sense of all that. So let's first of all try to classify the fruit and the fruit salad, and accept that we only have 4 strategies. The first strategy, as you can see, is subconjunctival filtration. Then we have things going into Schlemm's canal or going into the suprachoroidal space, or improving the conventional outflow through Schlemm's canal, and finally doing the ciliary body destruction, as you can see with diode laser or with a micropulse or whatever. Any of those 4 strategies can be ab internal or ab external, so from inside the eye through a paracentesis, or from outside the eye through the cornea. So now let's take a look again at the 4 methods to reduce the pressure surgically: subconjunctival filtration, enhancing Schlemm's canal and conventional pathway, going into the suprachoroidal space, and finally cyclodestruction. I will focus a little bit on suprachoroidal space because it's very interesting and it is blood free. So we initially had the SIPAS that was stopped, it's ab internal, and from there on we discussed the eye stent supra, which is something that is available. As you can see, it is very malleable, it is different in shape from the eye stent, and as you can see, the operation is done through direct conioscopy. It is not too complicated to implant one of those, as you can see here. SIPAS is very different from the eye stent supra. The eye stent supra is smaller in profile and human size. It has a curved profile, it is malleable, and it has these retention features versus fenestrations, and the material that is used is very different from the polyamide that was used for the SIPAS. There is a very interesting ongoing trial that you can find in clinicaltrials.gov, and we are really waiting for some results to come out. The last update was about a year ago, so soon we will be able to see this multi-center investigation study of the glucose suprachoroidal eye stent with cataract procedure. From there on, let's go to ab external approach. And here you see another implant. It's the MIGS. And again, it's an implant that is being put in the suprachoroidal space between the choroid and the sclera, as you can see here. And here you can see a video of the operation. It is quite a big implant, as you can see. But again, the implantation procedure is not very different from putting a SIPAS or an eye stent. And this is the results after 2 years. We went down from 23 to 13.8, which is 41% reduction. But very interestingly, there was no patients who had more than 30% loss of endothelial cell count, which is really a very important aspect that we need to make sure that the central corneal or the endothelial cells are not lost in with this procedure. Then we go to the subconjunctival filtration, and I will mention 2 procedures. The first is the micro shunt, also called the arrow, and you can see we mark at 3 millimeters, and then we create a pocket intrascleral, as you can see here. And this pocket is then perforated with a needle at 25G all the way into the antechamber. So this is a full thickness intrascleral tunnel that goes into the antechamber. As you can see the bevel coming into penetrating intracamerally, and then we slide this implant. You can see how it is being put into this pocket, and from there on, you have you can also use. There's also this knife that is very interesting to put the implant. And the other implant that I would like to mention is the Zen implant. It is a small implant that is being put into the bevel of a needle. And it comes with a very interesting injector, as you can see here. It works very well for people that are left-handed or right-handed. There's a knob that you take out and a small stoppage that you basically remove to be able to inject and free the handle so that you can inject the implant. The position, as you can see, is ab internal. So we go inside the antechamber, and from there on, we perforate into the subconjunctival space. Again, maybe this would be clearer for you. Here we are perforating with the needle. You will see the bevel coming out. Yeah, here it is the tip of the bevel. And then you inject the Zen implant into the subconjunctival space. And by the end of the operation, you will see it subconjunctivally. Here is in the antechamber. And if you do a little bit of irrigation aspiration of the viscoelastic that you injected prior to injecting the implant, you will see we remove the healing, and we have a blood that is formed immediately. Now, it is very important to know that MIGS are sometimes associated with complications. Here is a Zen implant that is perforated. I'll show you that again. It has perforated the conjunctiva, and we are removing it on the slit lamp with a tying stitch, very simply removed. And one complication that you have to consider is even when you take those implants out, sometimes a suprachoroidal cleft and hypotony develops, and that sometimes needs surgical repair. This is the cognitive bias codex, and it is very important to remember that one of those biases is peer pressure. Don't be under the influence of people around you that are doing different procedures. Make your own judgment, choose the procedure that you want to do, spend the time learning it, and that will be really your best friend. And maybe one day, as you can see here, we're using the Da Vinci robot to put an amniotic membrane on the cornea. You can see a very interesting stability of the Da Vinci code that's being used through joysticks, just like a PlayStation. And we can even, with the device, be able to take very clean and very interesting stitches. So is that the future? Who knows, maybe. With that, I thank you very much for your attention. It's an absolute pleasure to have been with you. I wish you all the best, continued success. And again, فخر كبير جدا بالنسبة لي وسعادة كبيرة إن أنا أكلم زملائي في اليمن السعيد. يا رب دايما أيامكم حلوة، ويا رب دايما نتقابل، وإن شاء الله نتقابل قريب على أرض اليمن.
Thank you very much, Dr. Tareq, for this valuable
a pleasure
presentation. But may I ask you a question? What's about this?
You can ask any question you like.
Yes, minimally invasive procedures. If you compare them with a standard trabeculaectomy or deep subscleral trabeculaectomy, so what's the result as a comparison?
Yes. First of all, we cannot put all MIGS in one basket. We have to compare every specific method to deep sclerectomy or to trabeculectomy. So having said that every method has to be compared separately, it is very rare now to find studies that did these comparisons, meaning that these comparative studies have not been done. But there are some retrospective studies that shows, for example, if you compare a Zen implant to deep sclerectomy, the deep sclerectomy results in a better reduction in intraocular pressure. It performs better than a Zen implant, and this is one example. For that reason, I'm using most of those MIGS devices in combined procedures in early to moderate cases and not in advanced cases. In advanced cases, I still use deep sclerectomy to be my primary procedure. And the indications for MIGS is mainly combined. And as I said, in some early cases, in cases where you want to go in and out rapidly, in cases where you want to have a bleb-free procedures like putting an iStent Supra or a mini-eject, in cases where you want to avoid hypotony. So you put something like the micro shunt, which has a much lesser chance of hypotony compared to trabeculectomy, but it is not, they have not replaced well-tested and well-tried procedures for moderate to advanced glaucoma standalones.
Thank you, Dr. Tareq. I want to ask about, is it safe and effective to use the Zen implant combined with cataract? And do you use it in mild or advanced cases usually?
No, not in advanced cases, always in mild cases. Yes, it is safe. It is effective, but you have to put a lot of effort. It's not just put there and you leave it to do its work, because in many cases it will scar, and in many cases we have to do a needling. So my needling for the Zen implants is about 30%, which is a lot, to be honest, because I don't have 30% needling after trabeculectomy or deep sclerectomy. But with needling, with very cautious needling, sometimes you get decent results, and then you are happy with what you have done. But it is not, as I said, if you're doing a phaco procedure and at the end of the procedure you take another 2 minutes, you put something in to reduce the pressure without having to keep the patient on medications in early cases, then there's a good argument for using MIGS devices. But this argument won't stand if it is an advanced case that needs low pressures for prolonged periods of time.
Doctor, last question, please. The learning curve of MIGS, learning curve in beginners.
It is very, very fast. It is much faster than trabeculectomy or deep sclerectomy. The procedure itself has been simplified. So you would not take as many time with the new devices compared to older conventional operations like trabeculectomy or deep sclerectomy, with one caveat: cases where you have to work ab interno into the angle, you have to be very good with direct gonioscopy. If you do not practice good direct gonioscopy, then it's not going to be that easy to perform.
Last question, please, from Dr. Assam. Last question, please.
I'd like to thank you for sharing with us this conference, and I'd like to ask you what are the advantages of MIGS over Ahmad valve?
Oh, many advantages over Ahmad valve. First of all, we believe that because of the size of the MIGS being relatively small, the potential for endothelial cell loss is significantly less than Ahmad valve. The procedure is easier to do, it's faster, and it is a hybrid procedure between a trabeculectomy or deep sclerectomy and Ahmad valve. Why? Because Ahmad valve, the main advantage is that you're filtering away from the limbal area. You are filtering in the limbal area in deep sclerectomy or trabeculectomy, but in Ahmad valve you are filtering very far away, 11 to 12 millimeter. Now things like the Zen implant and something like the micro shunt, they are filtering at 6 millimeters, so midway. So you do not get the absolute advantage of filtering away from the limbus, but you are also not dependent on limbal filtration, which is sometimes associated with rapid scarring. So few advantages MIGS over Ahmad valve in early cases. I wouldn't use Ahmad valve in an early case, but I also wouldn't use MIGS in an advanced case. In advanced cases that has been operated before, I would go for an Ahmad valve. The main advantage of Ahmad valve is that you can put it in an eye that has already been operated. But if a case has had trabeculectomy or deep sclerectomy, I would not go to MIGS after that. I would go to
Thank
Ahmed.
you very much for your time, Dr. Tareq. We really appreciate your
Pleasure.
professional.
A pleasure.
Thank you so much.
A pleasure. Just before I go, I am happy to see Dr. Deepak and Dr. Iman. So I just send them my very best regards. And I have to run back to the operating theater. It was an absolute pleasure to be with you. All the best for the rest of the meeting.
Thank you so much. Sorry for the delay.
Not at all.
Next speaker with us is